Good afternoon, everybody. Thank you so much for joining us this afternoon. Welcome to the webinar, Mental Health Courts, Solving Criminal Justice Problems or Perpetuating Criminal Justice Involvement. This webinar is being hosted by Mental Health America's Regional Policy Council. I'm Debbie Plotnick. I'm Vice President of Mental Health and Systems Advocacy here at Mental Health America, and I'll be moderating today's session. In this webinar, one of a series of webinars from our Regional Policy Council, we'll be exploring the evolving thinking at Mental Health America regarding the implications of mental health courts on the criminal justice system. Before we begin with our presenters, I'd like to mention a couple of logistics. All of the attendees on the phone are muted. If you have any questions for the presenters throughout the webinar, please just write them in the chat box that appears on the left side of your screen, and we'll address them during a question and answer session that will happen at approximately 4:15 this afternoon. A recording of today's presentation and all of the slides and any relevant materials or papers will be available on Mental Health America's website within the next 2 weeks. I'd like to begin by introducing Shel Gross, who's one of the members of our Regional Policy Council. And Shel has been the Director of Public Policy for Mental Health America of Wisconsin since 2000. He chairs the Wisconsin Council on Mental Health, and he also is on its Legislative Policy Committee as well as the Steering Committee for Wisconsin United for Mental Health, which is a statewide anti-stigma initiative. He's the past board member of the Wisconsin Prevention Network and co-chair of the Survival Coalition of Wisconsin Disability Organizations. Shel is also the project manager for 2 suicide prevention grants in Wisconsin, and also on a state prevention and early intervention grant, which again focuses on suicide prevention. He's also the project manager for building the Mentally Healthy Workplace, which is a Wisconsin partnership program with the University of Wisconsin School of Medicine and Public Health. Shel holds a master's degree in public policy from the La Follette Institute for Public Affairs at the University of Wisconsin-Madison and has over 40 years of experience in the mental health field. Prior to joining MHA, he worked for 10 years in the Wisconsin Medicaid program. We're very pleased to have Shel with us today. Shel, please begin.
Shel, if you just press *7 to unmute your line.
Hello.
Hello.
How are you today?
I am good.
Awesome. Are we about ready to begin?
The webinar has begun. If you could just mute your lines, please. Only our presenters should be unmuting their lines.
Shel, we're ready for you to begin your presentation.
On our side.
This is Shel. Can you hear me now?
We can hear you, Shel. Please proceed.
Okay, good. Thank you. I was trying to make sure that was working. Well, thank you very much for that wonderful introduction. I think it may end up being longer than my short presentation. I just wanted to first thank everybody for joining us today and just give you a brief overview of the issue of people with mental illness in the criminal justice issue, in the criminal justice system, to set the stage for today's presenters. First of all, on any given day, about 2 million people can be found in America's jails and prisons. Actually, probably a little bit more than that on a daily basis. But importantly, over half of these have some identified mental health problem. And as you can see from this slide, among those, the largest number are those in our local jails. And that's really going to be the focus of our presentation today, because mental health courts are taking place in local communities and trying to address the needs of that overwhelming number of people with mental illnesses who get involved in the local jail system. By the way, much of the data that you'll see in my presentation and some in the presentation that Mark Heyrman will be doing shortly come from a variety of position statements that Mental Health America has on its website. And at the end of my slides, there is a link to our position papers and a set of them that deal with a variety of issues around criminal justice and mental illness. So if you want citations for these, you can find them in those places. So in the next slide, we talk more about the scope. And while a large percentage have some mental health problems, 16% of those in state prisons and local jails have what we generally identify as a serious mental illness. And a smaller percentage, about half that percentage of those who are in federal prisons have serious mental illnesses. What we know about jails and prisons for people with mental illnesses, it's no place for them. Generally, mental health services are not adequate in those facilities. People with mental illnesses are often victimized or in most cases re-victimized because they've had some history of victimization in the past. And the environment in jails and prisons worsens mental illness symptomatology, especially when administrative segregation or isolation procedures are used, which is very often the case. So mental health courts are one tool for reducing the exposure of individuals with mental illness to incarceration. But such courts cannot be the only tool that we have in our toolbox. And we hope by the end of this webinar that what you will learn are the following: the benefits and the limitations of mental health courts, the characteristics of what we would consider to be good mental health courts, and additional options for diverting individuals with mental illnesses from the criminal justice system. MHA's vision is the long-term goal of integrating persons living with mental health and substance use conditions into a culturally competent, community-based mental health care system focused on consumer empowerment and quality of life and aimed at their recovery. So really what we believe is if people have access to timely services starting when they're young, we can avoid people even coming into contact with the criminal justice system. And that is going to be the solution that we would most like to see happen. We're not going to focus on some of those earlier interventions on this call, but it's important for you to know that that's an important part of our context. And here's a link for you to the position statements for MHA. If you go on the mentalhealthamerica.net website, you can easily also navigate to our policy pages and find these position statements. So I want to turn it back to Debbie to introduce our other presenters today. And again, thank you all for joining us.
Thank you, Shel. Again, this is Debbie Plotnick for Mental Health America, and I'd like to just do a brief introduction of our other three speakers, and I'm going to introduce them all together so that their slide presentations can move one right to the other. And again, I'll remind you that the webinar is being recorded. All materials, including the slides, will be available on the Mental Health America website within 2 weeks. And if you have any questions, please feel free to email me at Mental Health America, dplotnick@mentalhealthamerica.net. So we are very, very pleased today to have Mark Heyrman joining us from the University of Chicago Law School, retired mental health court judge Daniel Eisenstein from Tennessee, and Thomas Reed from Milwaukee. I'm going to tell you a little bit about each of our presenters, and then we'll turn it right over to Mark. So Mark Heyrman is a clinical professor of law at the University of Chicago Law School, and following a year of practicing criminal law, Mark returned to the law school as a clinical teacher, and he's been in that position since 1978. His principal responsibilities involve teaching effective advocacy to the students at the law school's Mandel Clinic, through supervising students in litigation and legislation advocacy on behalf of people with mental health conditions. He also teaches law and the mental health system with other clinical teachers and pretrial advocacy and intensive practice workshops. Mark is a member of mental health committees at the Chicago Bar Association and the Illinois State Bar Association. He was also, we were very pleased to have him as a board member for many years on the Mental Health America board, and we're delighted that he's with us on our public policy committee. And Mark is also a member and immediate past chairperson of the Illinois Mental Health Planning Advisory Council. Mark also served as the executive director of the Governor's Commission to revise the mental health code in Illinois back in 1988. And again, welcome, Mark. I'm also going to introduce Judge Daniel B. Eisenstein. And Judge Eisenstein is a retired judge of the General Sessions Court in Davidson County, Tennessee. And he also was the presiding judge for the mental health court there. Prior to that, he was a trial attorney in private practice and served as part-time administrative judge hearing special education cases for the Tennessee Department of Education. Judge Eisenstein received his Bachelor of Science from the Wharton School of Business and Finance at the University of Pennsylvania and his Master's in Special Education from the George Peabody College for Teachers. His JD came from the Memphis State University. He's currently a member of the Nashville Bar Association, the Legal Society of Middle Tennessee, and the Cumberland and Pro Bono Program of the Nashville Bar, as well as the Legal Aid Society. And we're also very pleased that Judge Eisenstein is a current member of the Mental Health America Board of Directors. Lastly, I'm going to introduce Thomas H. Reed, who is a graduate of the Northwestern University and the Cornell University Law School. He's been a member of the Milwaukee Trial Office of the Wisconsin State Public Defender since 1982, where he has handled a wide range of criminal cases. Tom served as the regional attorney manager since 2000 for an office of approximately 60 attorneys. He's a member of the board of directors of the Milwaukee Bar Association and a member of the MBA Legal Services to the Indigent and Courts Committee. He's currently a member of the board of directors for the Milwaukee chapter of NAMI and a community advisory member for the Milwaukee Secure Detention Facility, and is a steering committee member of the Milwaukee Mental Health Task Force. In addition to various other bar-related and teaching experiences, he's been an adjunct professor at law at the Marquette Law School since 1999. And now I'm going to turn it over to Mark to begin his presentation. Professor Mark Heyrman from the University of Chicago Law School.
Thanks very much, Deb. What I'm going to try to do is to give you an overview of mental health courts. Mental health courts have a great deal of variety, and therefore you have a lot of choices if you're going to create a mental health court, or if you already have one in your jurisdiction and you think it should be changed, there are many ways that you could change your mental health court. So what are mental health courts or problem-solving courts? They're courts to which criminal defendants who have been identified as having a behavioral health problem are assigned. Originally, they were just drug courts. So decades ago, many jurisdictions across the country created drug courts because they discovered, unsurprisingly, that there was such a large volume of people who were charged with crimes who had substance abuse and alcohol issues that may have been contributing to or involved with their criminal behavior, and they thought it would be useful to think about how to deal with the substance abuse problem as a way of dealing effectively and efficiently with these defendants. But then more recently, we have created special mental health courts for people who may not have a substance abuse problem but have a mental health problem, another mental health problem. We've also created special courts for veterans, which often deal with people with both mental health problems or substance abuse problems, and even prostitution courts. It turns out that lots of folks charged with this crime have substance abuse and mental health issues, and it may be useful to take those into account. So a mental health court creates special procedures and outcomes for people with various kinds of problems, including mental health issues and drug issues. Now, there are a huge variety among problem-solving courts in terms of eligibility, procedures, and goals. So if you've seen one problem-solving court, you've probably only seen one problem-solving court. In any given state, there may be quite a variety of different problem-solving courts, and you have choices to make if you're going to try to create one or change one. So, for example, the early mental health courts were limited only to people who were charged with misdemeanors. Now, across the country, we have more and more mental health courts that will take people with felonies. There are often limitations on what kinds of mental illnesses are eligible for a mental health court. And then there are lots of different ways in which the court is engaged with people in a mental health court. So sometimes the court will decide to defer prosecution. I'll talk more about that in a minute. Sometimes this will be part of probation or supervision. Lots of choices to be made. And you'll hear about some specific mental health courts from other presenters today. So what are the goals of mental health courts? First, to facilitate the processing of persons with mental illnesses in the court system. Second, to divert people with mental illnesses from prisons and jails, and we might do this for a variety of reasons. Lots of counties have said, it's just too expensive to have people with mental illnesses in our jail. It's hard to treat people with mental illnesses in a jail, and it's very expensive. And we could treat them more inexpensively if we adopted strategies to keep people out of the jail or out of the criminal justice system. And of course, because it's so difficult to treat people with mental illnesses in a jail, unfortunately, people with mental illnesses in jails and prisons are often victims of other folks in the jail or prison. We can treat people more humanely in the community. It is much easier to deliver mental health services to people in the community than it is to do so in a jail or a prison. And then, of course, we want to connect people to services. And so mental health courts and problem-solving courts always have a protocol in which people are an array of services are arranged and the defendant is offered those services. Now, another goal is to use the coercive power of the court to compel people with mental illnesses to accept treatment they have been refusing. That obviously is more controversial, but inherent in having someone charged with a crime, no matter how you arrange your mental health court, there is some level of coercion. If we say to a defendant, look, you've been charged with a crime, we are not going to prosecute you if you will only agree to participate in mental health services, the defendant knows it is told to him or her clearly, if you don't cooperate, we will go ahead and try to prosecute you, and you may be convicted, and then you may be punished. And if you're put on probation as part of a mental health court, your probation can be found to have been violated, and that's a sanction we can use. And so while you can arrange your mental health court in a variety of different ways, there always is this inherent coercion because mental health courts are part of the criminal justice system, and they're designed to in the end say, look, we have the power of the criminal court, which can do something that you don't like to you if you don't participate. Of course, one of the goals is to reduce recidivism. The theory is that punishment often is not particularly useful for people who have committed crimes and the crime may be connected with untreated mental illness. And putting someone in jail may not have any beneficial effect on that, whereas if we offer people an array of services and they're connected to services that they like and wish to continue with, that may very well reduce people's involvement in the criminal justice system, which is good for them, one hopes, and good for all of us. And then also to respond to social problems created by untreated mental illness. So sometimes mental health courts have been connected to so-called broken windows policing. This is even more controversial, where people who might not otherwise have been arrested are arrested because we don't like folks hanging around. Only a few courts have been focused in that way, and most mental health courts are not. So how do mental health courts work? Well, basically they require an agreement. Everyone must agree. But again, the agreement of the defendant is also often the result of the fact that there's criminal justice prosecution hanging over the defendant. So it almost always requires the agreement of the prosecutor. It requires, in the end, the agreement of a judge, and there must be a community treatment plan. So treatment providers must agree that that this plan will work for a defendant. And then the plan is implemented, as I suggested, through a variety of different ways: deferred or suspended prosecution, supervision, or probation. Additionally, the judicial involvement varies a great deal between and among mental health courts. So in some mental health courts, the judge is very actively involved and will know a great deal of the details of the defendant's history, his or her involvement or lack thereof in the mental health system, past failures, what kind of treatment is being proposed, and the judge may very well believe that it's helpful to have a conversation and indeed even a relationship with the defendant to encourage the defendant to participate. Other judges have a much more hands-off approach and say, look, if the prosecutor agrees and the defendant and his or her lawyer agree, I'm happy to agree to it as long as it's working, and then you'll come and tell me if it's not. Both of those kinds of mental health courts, there's substantial evidence work. There's some evidence that additional judicial involvement makes things work a little better, but that evidence is fairly anecdotal and not very strong at the moment. So again, there are consequences if you're in a mental health court, and there's a failure. That is, the conditions of treatment are not complied with by the defendant, or he or she gets in additional criminal trouble. So there can be, the prosecution will commence, probation can be revoked, and the defendant can be imprisoned. So the consequences can be quite severe. Do they work? Well, the answer is that there are substantial reductions in criminal justice and mental health recidivism, both for people who are involved in mental health courts. And by that I mean it's hard to do this research, but the research shows that people who have had extensive involvement in the criminal justice system often are removed from the criminal justice system if they've been carefully connected to a mental health court. So in some jurisdictions we've seen 65 to 75% reduction in arrests and in the number of days that people spend in jail, which of course is expensive and not particularly good for defendants. And we've also seen reduction in the number of days that people spend in hospitals, the number of times people go to hospitals. But it is difficult to do a random assignment. It's probably unconstitutional to do a random assignment, since you can't say some people will be found guilty and some won't. And pre and post studies are inherently flawed. So we must say that the research is not without its challenges, and so we can only say tentatively that these mental health courts work. But lots of courts have found that they have saved the county money, and the only way you save a county money is if you have fewer people in a jail. So as I suggested, the involvement of the judge has been shown to have a modest positive effect, but the most important thing that happens with mental health courts typically is that the creation of mental health courts brings together a large group of people, including treatment providers and the court system, in a cooperative effort to make sure that services are coordinated. And in many jurisdictions, services for people with mental illnesses are lacking, and of course then they're also lacking in the criminal justice system. So if we have more services and more money and better coordination of services, we're apt to have better outcomes for people. Again, the question is that what causes the beneficial effect of the mental health court, or is it the coercion? It's hard to answer that question clearly. One of the problems we have is that typically the defendants who agree to participate are people who have been involved more frequently in the criminal justice system, so they have they have more incentive to participate in the mental health court, so there's a selection bias in terms of who gets into a mental health court. We typically, and for darn good reasons, focus on recidivists, not on someone who are first-time offenders. So one of the concerns about mental health courts, what are our arguments against them? Well, one of the things that people are worried about is that they may criminalize people with mental illnesses. If we arrest people who would not otherwise be arrested in order to put them in a mental health court, that may end up having serious negative consequences for people. And most jurisdictions have, in a variety of ways, avoided doing that, in part because it ends up costing the county more money, and therefore counties are reluctant to do this. Of course, if you arrest people who would not otherwise have been arrested just so they can be in a mental health court, then they may have a criminal record which has negative consequences for all kinds of other things that are important to everyone, including, of course, people with mental illnesses. Employment, housing, child custody, relationships in one's family and in the community. So as a general matter, mental health courts have not adopted strategies to arrest people who wouldn't be arrested because in the end, that often hurts people and does not reduce recidivism, does not save a county money, may end up making almost everyone worse off. Of course, another complaint is it uses inappropriate coercion, that we shouldn't be using coercion in this way, and that there are better ways to solve the problems, and we can do this without the coercion of mental health courts. And so the argument is that we could achieve similar or better results if we simply spent more money on people with mental illnesses without having the coercive effect of the courts. Another argument about mental health courts is that they may divert scarce treatment resources away from voluntary patients. So if a court gets involved and we create a mental health court and the mental health system responds by saying, oh, this will now be the focus or a priority for our spending our resources on people with mental illnesses, that may take away from people who need resources desperately, who need mental health services, are perfectly happy to go, but we don't have treatment for them. So we may end up cutting off treatment to people who want it, and then those folks may end up in the criminal justice system where we then have this coercive intervention. So in thinking about creating a mental health court, one needs to think about where is the money coming from. Is the money coming from the traditional mental health sources, or is it additional money that might be coming from the criminal justice system? The good news is that lots of the money for mental health courts has come from the criminal justice system. And then another thing that it's important to remember is that most criminal behavior, including criminal behavior by people who have a mental illness, is not primarily caused by mental illness. So most of the people in the criminal justice system, as I suspect most people on this call know, do not have a mental illness, and even many of those who do have a mental illness may be committing crimes for reasons that are unconnected to their mental illness. So if you're going to now have a coercive treatment arrangement and that causes people to get treatment when that wasn't the reason that they got arrested, that isn't the basis for their criminal behavior, the mental health court is unlikely to be beneficial to anyone, isn't going to solve the problem. So let me just sum up by suggesting these courts will only be created and maintained if in the end they save government money. If they don't save government money, mental health courts go away. So that's actually a good point, because it seems to me that if in the end you're putting more people in jail than you would have before you created the mental health court, counties are not stupid. They won't continue to create mental health courts. It isn't helping them. So some mental health courts that have rounded up people who wouldn't otherwise have been in the system have discontinued or have changed themselves so that they only are treating people who were repeat players in the criminal justice system and were taking up a lot of the county or jurisdiction's money in the jail. Another thing that's important to think about is it's almost always better for someone with a serious mental illness not to be in jail. Again, people with mental illnesses don't do well in jail. It's perhaps the worst place for someone with a mental illness. Jails, unfortunately, are violent places, and despite the efforts of lots of dedicated people, it's difficult to get decent mental health services in a jail or a prison. Mental health courts have an additional benefit. They often have attracted money which would ordinarily not be spent on treatment. So the federal government has spent some money and given money to the states to encourage them to create criminal justice diversion programs, including mental health courts. So quite a few mental health courts that have been created around the country have been created not with traditional mental health money from your Department of Human Services or your Division of Mental Health or even from Medicaid. They've been created with money that the criminal justice system thought it was wise to spend because there are so many people with mental illnesses in the criminal justice system, and that's people in the criminal justice system tend not to like that. So to the extent that we engage people with mental illnesses in effective treatment, mental health courts can improve their lives. It's important for us to think that mental health courts, if they're used, need to be used as part of a larger program. So the Substance Abuse and Mental Health Services Administration, SAMHSA, has lots of materials about this, and they have suggested that if we're going to deal with the excessive number of people with mental illnesses in the criminal justice system, we should use what they call, what many people call the sequential intercept model. We should be intervening as early as possible, getting people before they're arrested, of course, but if they're arrested, trying to keep them from being charged with a crime, trying to keep them out of court rather than having them end up with a criminal justice record, having them end up with being convicted and end up in prison or jail, that we should look at every single step in the criminal justice process. But the earlier that we can intervene, the less negative consequences for the defendant with a mental illness, and the cheaper it is for all of us if we keep people out rather than having to rescue them or divert them later on. That's my summary.
Thank you so much, Mark. Now we're going to hear from Judge Dan Eisenstein from Tennessee. Judge Eisenstein?
Hello, am I on?
You are, Dan. Thank you. Please proceed.
Thank you so much. I want to thank the Mental Health America for inviting me to participate in this program today. I had the honor of being elected a judge in Davidson County in 2004, and part of my duties as judge, included the mental health court. I also was responsible for the regular duties of a judge at criminal and civil matters. Davidson County Mental Health Court is one of the first courts in the nation. It was founded in 2001, and it came about through a grant. The judge actually that received the grant and started the program decided to move to a different court, and his position became available shortly after he began, and I was asked to run for the position because of a background in mental health before I became a judge. And luckily, I was able to prevail in a primary and a general election, and was subsequently elected a second round, and so served for 10 years. When I came on board, the grant was ending, and consequently, I was charged with getting it funded through the city government, which I did, and really wasn't a problem. We, as being a new court, and really had to feel our way through at the beginning. I've set up our mission, and it's probably the mission of almost all mental health courts in the country. When we started under the grant, and then when I started, we were limited to 50 people, approximately 50 people, who were charged with misdemeanors, nonviolent, and had been diagnosed with a mental illness. And our duty was to obviously try to divert them from the program, the criminal program, through a diversion program, or not pleading and coming open, and then having them work through the system. You've heard a description of how mental health courts operate, and that's a pretty good description of how we operated and how I set it up in 2004. The program description is provided above it. We were the point persons for people coming in the criminal justice system who had diagnosis of mental illness, developmental disabilities, or dual diagnosis. And our job was to get people out of jail as quickly as possible. We reviewed initially over 400 cases a year. The next slide just shows the staff, and it's pretty standard the way it operates, a court operates. I was a hands-on judge. I had a background in mental health. Before I became a lawyer, I actually directed as a baby almost, 25-year-old graduate from graduate school, a program at the mental hospital, psychiatric hospital in Middle Tennessee, and did that for several years before I went to law school. So I remained involved in the community throughout my career as a lawyer of almost 28 years in mental health, and actually was a founder of a program that grew very large to provide services for folks who had been diagnosed with mental illness. So I was pretty well entrenched in the idea of working with people who had been diagnosed with mental illness. So I was a hands-on judge, and probably some people thought too much, but I certainly enjoyed it. The procedure as set up is one's arrested, it's referrals made. Most everybody we saw came through the jails. Very rarely was somebody out of jail when we got them into mental health court. And if they proceeded successfully and graduated, we had a graduation program. One of the things that we were able to secure some 5 years after I started was a federal congressional grant which allowed me to work with a residential drug court to have folks that were dually diagnosed and had significant drug problems to run them through a special inpatient program at the drug court. And then I supervised the outpatient program after they got out. And this was very successful, and it's still going on now. We were able to secure funding, ongoing funding. So it's been a very successful program. I think it's the only one in the country. One of the big issues is recidivism, as has been stated before. And we were able to reduce that amount significantly. Now, this is only for graduates. A lot of people don't graduate. So those that don't graduate, these numbers aren't actually applicable. But we were able, for the first number of years, to keep the recidivism rate under or about 10%. It has risen over the last few years for various reasons, which I'll get to later. But we followed the people for 2 years, and if they were never convicted of a crime, that's how we came up with those numbers. It was pretty amazing. I saw very few graduates come back through the system. This gives you a chart, this next slide, of breakdown of our participants. It has changed over the last few years. That goes up to 2009. We saw a lot more schizophrenia over the last several years, a lot more serious offenses also came through our system. The next slide is an interesting slide, and it's one that was prepared by a study that was done by the legislature that I worked with. And it shows a timeline of what happened in Tennessee. And Tennessee had a very progressive program for everyone that provided insurance for everybody. It's preceded Obamacare. It was called TennCare. And it was in effect when I was elected, and everyone was eligible to get not only medical insurance but behavioral health insurance and services. Thus, the court was small because a lot of people most people had services. As a result, we saw not a huge number of people going through the correctional system. In 2005, TennCare went away in Tennessee, and 21,000 people suffering from serious mental illness, serious and persistent mental illness, were cut from the rolls on one day. And subsequent to that, Tennessee cut away the TennCare program, and we're really a Medicaid program. And as a direct result, we had a huge increase in people being incarcerated, which makes sense because services went away. People didn't get the medication they needed, didn't get the services they needed. Symptoms increased, and as a result, more people seem to be getting in trouble. You can see the 5-year period from 2006 to 2011. What happened, that number has continued to grow. And the reason for this was pretty straightforward, and that is because of the cuts in TennCare, services just went away, and the money went away. And as a result, people lost a lot of help. And also at the same time, the mental health institutions began to close, others limited the numbers that could come in. So, for example, if someone was found to be even need of involuntary committal, if the hospital was full, you were put on a waiting list, and as a result, some people ran into the correctional system because of that. And then, as always happens, if it's not in front of you, a lot of people just don't realize what's happening, and that's what I call out of sight, out of mind. And Tennessee lost many of its services. They developed a safety net program, but it wasn't nearly as inclusive as the services before TennCare left. So as you've heard earlier from Mark, what seems to be happening, and it's not only in Tennessee but all over the country, is we're seeing more and more people wind up in local jails. In fact, in Davidson County, the jail for Davidson County is the largest. It has the most folks seeking mental health treatment in Middle Tennessee. Many, many more than the regional psychiatric hospital. That hospital has just 168 beds for 36 counties. So what we've seen is a dramatic increase, and I saw it over that 10-year period, a dramatic increase in folks coming into jails. And I was perturbed about this and have made my thoughts known in Davidson County, and now presently working on some issues to try and resolve that problem. My belief is that the solution is more money and more resources directed at early intervention. And Mental Health America before Stage 4 is right in line with that. What happens is that people don't have services, and as a result, symptoms develop. Many times the police are called, and then you get into this whole cycle of incarceration. And in many cases, I don't believe that needs to happen. And the solution, in my belief, is just more money and services at an earlier stage. So that's an overview. I hope it's helpful. Thank you so much.
Thank you, Dan. That was terrific. We're now going to move to Thomas Reed from the Milwaukee Defender's Office. Tom, please proceed.
Okay, am I on?
You are. We can hear you
excellent.
fine. Thank you.
So I have the advantage and disadvantage of following two distinguished people, and for those of you who have been listening to this, I think you have been given a look at mental health treatment courts and the related issues in a couple of really valuable ways. And so I think what I can add to your understanding today is to kind of bring you into the world that, you know, lawyers who are representing people who have these difficulties, what they face, and I want to give you some context around what that experience is and sort of build on the point that Mark brought out earlier, that there needs to be a spectrum of responses, not a single response. Mental health treatment courts have a place, but they're not the entire solution within the court system. So let's look at this first slide here. You know, the people that typically we see in the criminal justice system who have mental illness and who are very symptomatic typically have very confusing and complex psychiatric and personal histories. What I mean by that is just simply that the plight of individuals who have chronic mental illness in a lot of our communities, Milwaukee is certainly an example of this, have difficulties with a lot of things that compound each other. So there are housing issues, and there are frequently very difficult relationships people have with families. There are difficulties people have just with the economics of living in the modern society. It's very difficult to maintain employment. It's difficult to maintain a good relationship with systems that provide benefits for you. There is a tremendous amount of stigma, and that is different in different neighborhoods and communities. And so we see people who come to us and they're in a lot of trouble. Many of them also have co-occurring disorders, so they're using alcohol and drugs. There's frequently homelessness. And so this picture of people who have mental illness is a very complex picture, and it's hard to take apart and know exactly what it is that is involved. I will make the point that the numbers that Shel Gross put up about the high rate of people in criminal justice status in jails and prisons with mental health issues, we think those are very accurate. And teasing out behavior, what behavior is caused by mental illness and what is caused by something else is extremely difficult. And it's difficult in two ways. Some behavior, which it looks very organized and purposeful and deliberate and would seem to justify the conclusion that this is an individual who has sought to do something harmful to other people. Sometimes that very organized behavior is tied directly to delusional thinking, and it is not at all purposeful in any meaningful sense. And there are sometimes disorganized behavior that is really not so much symptomatic of mental illness as we might think. So the second point is really critical. In our way of understanding people who are in trouble in criminal justice, we have got to really respect the complexity and be curious about it. All too often, people come in, they get pigeonholed, and that curiosity is lacking. We see a fair number of people with mental illness who are seen as disciplinary problems in jails and prisons, and they end up in segregation units and other punitive status, when in fact the most obvious thing when you get closer to the situation is that's not really what it is at all. When you go into those jails and prisons and you see people in such distress, and sometimes as a lawyer, they won't bring an individual out to the visiting room. They'll bring the lawyer into, a segregation cell, and it's, just a very daunting environment, very hard to even describe in any accurate way. But your thought is, I've got to do everything humanly possible to help this person get out of this environment because it is destructive. Just to be there is destructive to my own well-being, much less what it would be like if I had a mental illness and I was stuck in this setting. And that can lead to a lot of mistakes that lawyers make in the way that they treat people, the way they think about what they're trying to accomplish, and the willingness to listen carefully to what people are telling them. All of those things are easy mistakes to make, and it's important to point out that we have to be really careful about this. The last point here on this slide, I think, is almost self-evident. Because of the complexity of these things, the representation of individuals who have these problems requires a great deal. And I must say that our law schools do a very poor job in preparing people for this kind of representation. And even among lawyers who aspire to be quite knowledgeable about it, the amount of time that a very busy lawyer has to understand the realities of living in community mental health programs or living in a institutional setting or being familiar with the vagaries of medication, these are really difficult tasks, and for the want of that knowledge, a lot of mistakes are made. So this is just to say something about the complexity and difficulty of our task. So what I'd like to do next is to start giving a couple of simple distinctions that many of you listening to this already know, but are just worth touching on. There are a lot of people who are very symptomatic in our communities, who the neighbors, the merchants, someone is calling the police and saying something has to be done. And we need to recognize that the criminal justice system is not the only or even anything like the best response, even though police are oftentimes the ones who are called to as first responders in these situations. And we do have civil commitment and criminal justice responses. In both cases, a person can be taken into custody. In the case of the civil commitment, which we won't go into very much, the question typically is this person a danger to themselves or to others? And if they are, is the state justified in taking steps to have them institutionalized, or in other ways having them be involved in a required set of interventions to control their behavior? And the criminal justice response is to arrest someone, bring them into the criminal justice system. And a lot of that behavior comes into the criminal justice system as disorderly conduct, as assault and battery, as things of that causing disturbances. And this behavior, with one officer who is trained in the most modern way in terms of understanding mental illness, what's called CIT policing, may be taken to a mental health facility. The next officer who lacks that training and the time of day is the wrong time of day can end up in the jail and facing criminal charges. And unfortunately, these systems don't communicate very well one to another, and we see a lot of difficulties as a result of that. And we could talk about people who start out in the civil system and they punch the nurse, and then they end up in the criminal system, and a lot of things can happen. And so one of the goals long term is to bring these systems a lot closer together, and one effect that's already been commented on is that mental health courts become this point of collaboration that is long overdue. Now, we've heard so much about treatment courts that I feel like it would not be a valuable use of anyone's time for me to add too much to it, but I do want to make a couple of points. Treatment courts, I think, are extremely helpful and easily understood when it comes to people who have addictions, because you can get someone to a point where they are not using alcohol or drugs, and if you can stabilize them around that, then they do much better. With people who have mental illness, most but not all mental illnesses tend to have a life course. They get better and worse over the time that people have them, and it's not as easy to declare victory, as it were, to prevent recidivism. But I do think that it is often lost in understanding that people, when they're properly cared for, live in recovery quite successfully throughout their life with mental illness, and they are able to achieve things that are unimaginable when you see someone sitting in one of those jail cells I referred to a minute ago. So while I do want to highlight that it's a little harder with mental health treatment courts to achieve the long-term successes that sometimes are possible with substance abusing individuals, I do think it is possible to get people into recovery, and it makes a big difference. I think that mental health treatment courts really need to be focused on serious crimes, and we're going to talk about that a little bit more in just one second. I also want to say about treatment courts that a problem that frequently arises has to do with the monitoring of compliance. And I think the philosophy that we see, here in Milwaukee and other places is that we want to hold people accountable when they are not living up to the terms of their agreement. But for this population in particular, given the complexity of their lives, it's very difficult to be in perfect compliance. There are housing problems, there are transportation problems, there are access to benefits problems, there are family stresses that people encounter. And so figuring out who's not complying and what it means that they're not complying and how to help them to comply better is one of the really real arts of doing this kind of work effectively, and the courts really work hard on it. It is important, however, to pay attention to this next slide. Risk and needs levels are important. There is really important evidence that shows us that when people come into the criminal justice system, we can assign through various actuarial tools levels of risk for reoffense and for failing to come to court. And the predictions on mental health are a little bit more precarious, but still we do see pretty strong indications that when you respond to someone in the right way, you can help them to succeed. And when you over-respond to them, you can have failure. And this slide at the last bullet point kind of shows you why it is that we don't want to have people in a mental health treatment court who can be managed much more effectively with a much lower level of pretrial supervision, or perhaps with a diversion agreement or something that would sort of pull them out of the criminal justice system. So the people who optimally are in these treatment court models are people whose behavior requires us to take it very seriously. And the example I want to give you, case that we had in the office not too long ago, an individual with very significant paranoid delusions became convinced that a neighboring house was the home of people who are great potential harm to him and to others. And so at the height of one of these delusional moments, he rolls a garbage cart up against the side of the house, fills it full of newspaper, sets it on fire, and immediately singes the siding of this house. So he is arrested as a result of that for arson of a building, which is a major felony. And if you do that for deliberately, and it's proven that you did it deliberately, you're likely to go to the state prison system for a long time. But it was so apparent that his thinking was distorted because of the schizophrenic delusions that he was having, that he's a person who would be a good candidate for this kind of intervention. He needs a lot of work and a lot of attention and a lot of scrutiny, and the public safety demands that there be a lot of scrutiny. And working someone like that out of the spot that they're in and back into a community placement is what a treatment court can be quite successful at doing. You can harm people who are lower risk, who don't really need that kind of intervention. This little picture that's in front of you right now, it just shows you all the different things we're doing in Milwaukee with and how each one is tied to certain risk scores. And I like it because it sort of, in one glance, allows you to see that as we see higher risk, we start increasing the intervention. That's the key point. And we want to make sure we're doing that match between the risk levels and the intervention in a correct way. This next slide, I think, highlights some things, again, which have been alluded to. It's one of my problems coming sort of at the end of the program here. But I can't overstate how each one of the things that is on this list is a requirement of, the people in the criminal justice system and the people in community service who, we rely on to help people who are in trouble. We'd like to keep a lot of the criminal defendants in the community services. These are the things that really we have to be very honest and direct about in terms of understanding what they are and what they mean. It's easy, for example, to use the word trauma. I can almost use it for any bad experience that I have. If I said to somebody who's listening to this, well, I had a terrible traumatic experience, I had a car accident or something, unless it was minor in nature, I still wouldn't be looked at askance for having used the word trauma. But we really want to be smart about what these terms mean, because they are, in their pure form, in their definitional sense, they identify things that are fundamental obstacles to people making progress. And the fourth one down, I think, is one of the ones that is frequently not spoken about in as clear a way as it needs to be. And to the clients that we represent, that's a complete non-starter, because so often the life of people who live with these illnesses is really difficult. It's painful. It is full of so many disappointments, and the capacity of many of the individuals have to really bounce back isn't just the resilience factors are not as accessible to people, and so they really struggle. And when a lawyer comes in, when a judge comes in, when a prosecutor comes in and says, guess what, we're gonna make it all better. You don't have to spend more time in jail, but you need to do X, Y, and Z. You need to go to this good program. A lot of the clients have been to those programs or to that specific program. They've been on the medication, and the last time they were on it, they gained 100 pounds and they were diabetic and felt horrible. And so I think clients come to these kinds of courts with a reservoir of very bad experiences with our mental health system. And I think unless we're able to have meaningful, honest conversations, and where judges are actually very interested in listening to individuals talk about what those experiences are, and then help to reframe those experiences in a way that, yes, I know you've had these bad experiences, but here we have a new treatment provider. It's an evidence-based program that's going to really avoid some of the things you've experienced. It's very difficult to win the confidence of people, and then if we don't have that confidence, it's hard for people to take all the risks that we ask them to take in order to get to a place that's better for them. Recovery is risky for people with these illnesses, and it takes a lot of courage to go down that road, and our criminal justice system is not built enough on empowering people, rewarding them for success. It's much more like, if you don't do what we tell you, something bad's going to happen, and the evidence tells us that's not a great way of motivating people. Last kind of point that always is worth talking about is that the public concern at all times is about public safety, and violence is a particularly distressing thing. Milwaukee is not alone this summer in having had a rise in homicide rates and shooting, and we have in neighborhoods where I heard a recent speaker call it areas of concentrated disadvantage. These rates of violence are very substantial and concerning, and so it is very easy to correlate people who have mental illness with violence. It's just a thing that happens all too often. What we know is that that's not what happens, that people who have mental illness are much less likely to commit acts of violence. The nature of these illnesses is stigma, and the stigma that's attached to them causes people to retreat, to isolate, to feel ashamed and embarrassed and uncomfortable, and that actually makes them at much greater risk to be victims of some of this stuff than the perpetrators of it. So last slide here is just to talk about, well, what are some things that we need to be doing? Obviously we have to train criminal justice professionals to understand a lot more and be interested in a lot more than just doing cases and resolving criminal charges. We need, and for this kind of effort, we need to have all system participants seriously committed to having the requisite knowledge and interest, and we should be having mental health treatment court professionals out at the county mental health complex and sitting on the ward and talking to individuals and involved in other kinds of things that allow them to have a deep grasp of what these issues are. This next bullet point, focus more resources on each individual. One of the things that I'll highlight for you is that the individuals who end up in treatment court are individuals who are also on a regular basis in our emergency rooms, because a lot of these illnesses come with medical symptoms. They're in our mental health hospitals. They're in our community mental health. They're in our housing. programs, they're very high consumers of a lot of services, and we let people migrate or cycle from one thing to another all too often. And if we just focused on, for each community, the 200 people who are in a big community, or the 50 people in a moderate-sized community, or the 25 people in a smaller community who really are the ones where coordination of healthcare and mental health care can make a difference, we might do as much good as all the mental health treatment courts that we could create would accomplish if we just worked more aggressively with that cohort of people. And I think that the other two things are worth noting, and especially the last one. We've had a history in the United States of having a commitment to treating people's behavior through the lens of criminal justice, holding people accountable. We've made the criminal codes thicker and bigger all the time, adding penalties and consequences. The fact of the matter is the criminal justice system and policing is not the answer to a lot of problems. It is part of the answer, but the collaboration with housing, the collaboration with public health, the collaboration with mental health treatment providers, the collaboration with community and neighborhood and economic development strategies, all of these collaborative structures are what keep communities growing and becoming healthy. And we can no longer really afford to have the criminal justice system off on its own, imposing its taking, making the decisions it does, because oftentimes those have destructive consequences for the lives of the people who return right back to the community. And so mental health courts are a prime example of how powerful collaborations across a number of systems can have much better effects. So with that, I will return you to the chairperson.
Thank you so much, Tom. Thank you all to our wonderful speakers. We're going to open up for questions now. Please do submit your questions. We already have a bunch of questions in our chat box. If you would like to ask additional questions, please do put them in the chat box. And I will direct some of the questions already are for some of our presenters. And otherwise, presenters, please feel free to chime in. We have a couple questions related to the Tennessee Mental Health Court program. So, of course, they are to Judge Dan, asking about setting up an inpatient program as part of the drug court, and asking about funding for drug courts. Judge Dan, would you like to talk about that? And
Sure.
When you are talking about it, one more quick question. I'm going to couple it with you with the percentage of folks who graduated, who matriculated in and then graduated from the program.
Okay, thank you. The collaboration with the residential drug court here in Davidson County was something that Judge Seth Norman and I, Judge Norman runs the residential drug treatment court. It's one of very few in the country. Began talking about soon after I was elected in 2004, because both he and I had many of the same type of issues with the co-occurring drug addiction and substance abuse and mental health issues. So we worked together and proposed to Congress a plan where I could send, initially it was up to 10 people, to a special unit at his drug court, which I would staff along with him with mental health professionals, and with the idea of working on the addiction problem along with the mental health problems, because before you can get to the mental health problems, in many cases, you have to get over the substance abuse problems. And it was very successful from the day we opened the doors. We were very successful. And it is still going now. We were able to secure funds, ongoing funds, and it's still occurring. And it helped both programs because it provided staffing that Judge Norman didn't have on the mental health side, and it helped me with the drug addiction and substance abuse side. But this was unusual funding. It was through a congressional grant. It took took a number of years to work it through, but it was well worth it once we got it. There are other grants that are available that come across people's desks all the time, but this we sort of set up our own and did it our own way, and we were successful. The other question about the percentage that graduate, I have been off the bench now a year, so I can't talk to the last year or so, but the last several years I was on the bench, our court grew from 50 people being supervised at a time to over 200 at a time. So it grew dramatically as more and more people found their way into the correctional system. We were graduating about 100 people a year, but that wouldn't be 50% because some people are in, some people are out over a period of time, depending on how they're doing. But we were fairly strict on the graduation, frankly, in the sense that we had to really work the program and do a good job. We had a lot of people that completed, but we didn't actually graduate because of some problem that developed. So we didn't include those. But the last year I was on the bench, I think we graduated about 100 folks during the year, which was a pretty good number of folks. And that's where we came up with the recidivism numbers. We just used the graduates as opposed to the other folks because we had a hard enough time tracking people as it was, but those are the folks we used. Hopefully that answers the question.
Thank you, Judge Eisenstein. We have a couple of questions for Tom. If people had asked some questions about earlier intervention and the difference that would make in your opinion, and also a question about the disposition of the gentleman's case that you had mentioned who had started the fire at the neighbor's house.
So I think for early interventions, I think there's that's a term that can mean a lot of things. So let's talk about two aspects of it. So when we talk about early interventions inside our legal system, what we mean is things where someone is arrested and brought into the criminal justice system at the front end. We do a risk and needs assessment, and depending on I won't go into all the details, but there are criteria that are used to select people for diversions, which means that they're not charged at all, and they are given certain requirements, and if they comply with those requirements over time, then the state permanently elects not to bring any criminal charge. Another is a situation where there's an agreement, the person essentially pleads guilty, but the sentencing is delayed for quite a while, sometimes as long as a year or more, and during that year the person is given a set of requirements to comply with, and if they're successful in that period, then a felony they would plead guilty to a felony, but they would end up being convicted of a misdemeanor, or they have a series of misdemeanors and those would be dismissed, and there would be no sentencing, and the guilty plea would be withdrawn. So there is definitely early intervention of that sort, which is tied to risk levels, so that people who don't seem to need the highest level of judicial involvement, which is a drug treatment court, mental health treatment court, end up in early intervention. There is also early intervention in the sense that we would like to have our police officers have this CIT training so that they know how to work in the community. We would like to have some clinicians who would be available to police officers in a lot of these street encounters on a kind of mobile crisis model. We would like to have some drop-off centers for police who see someone whose behavior is clearly a problem but does not necessitate yet an arrest and criminal arrest or a referral to a mental health facility for an emergency detention. So early intervention can be kind of preventative and street-oriented around policing and community mental health, and it can also be inside the criminal justice system. The individual who you asked about, was successful in bringing what's called a not guilty by reason of mental disease or defect plea, and that resulted in a community placement in his case. But he was subject to a form of what is simply described as a kind of probation supervision, but it's tied to the special legal status of that plea.
Thank you, Tom. We actually had another question. Perhaps you or Mark would like to answer it about the not guilty but by reason of insanity and how that plays in at mental health courts.
I'm happy to answer that.
Sure, Mark. Go ahead, please.
So the insanity defense is rarely invoked and rarely used, and it really is not used in mental health courts. So this is a way of diverting people out who wouldn't be eligible for an insanity defense. Very few people are eligible for an insanity defense, and if anything, the insanity defense has been narrowed in most states in response to the attempted assassination of President Reagan and the acquittal of the person who did that. And 5 states have actually abolished the insanity defense. So while the insanity defense can get some people out of the criminal justice system, it doesn't help very many people in that way. And so and it usually is used appropriately only for very serious crimes, including murder, whereas mental health courts are typically used with nonviolent crimes and already are and are likely to be a way of diverting many more people out of the criminal justice system than the insanity defense ever could.
Yeah, I think I would say that the insanity defense typically carries with it a very extended period of intense supervision, and for a lot of reasons that is only appropriate for some very serious kinds of cases. So where we see it is in cases where you're talking about people being homicide cases and cases that are have that kind of very aggravated quality character.
Yep.
In Tennessee, there has never been in a trial a successful insanity defense. So the only time we see it in Tennessee is if the prosecutors basically agree to it. It's normally for more serious incidents, but never been successful use of it in a trial. So very, very hard.
Thank you, gentlemen, for the answer to that question. Again, here's a question any of you can feel free to answer. It's asking about requiring defendants to plead guilty and to waive their right to counsel so that they can come into a mental health court. How do you balance protecting people's rights with getting them into treatment?
Well, you certainly shouldn't, no mental health court should require someone to waive their right to counsel. It is true that some people in mental health courts, if they're charged with low-level misdemeanors, may not have a counsel, but in my view, it's almost always better if the defendant in a mental health court has counsel. As I think all of us have suggested, if possible, it's better to use deferred prosecution or some other mechanism as opposed to a plea of guilty to get into mental health court. Sometimes the only appropriate mechanism is a plea of guilty. But again, that should only be done if and then a sentence of probation involving mental health services. But that should only be done, in my view, if you've consulted with your lawyer and your lawyer thinks and you and your lawyer agree that this makes sense for you and is not going to end up with you being worse off.
Well, I think one. Oh, go ahead.
Go ahead. Well, I was just going to say, in my mental health court, everybody was represented. There was never a case where we had an unrepresented person come forward, and in most cases, frankly, it was the defense lawyers and public defenders that were seeking the mental health court intervention. But we would never, ever and I think that's probably true in all mental health courts. I can't believe there's one where a person would not be represented. And as both of the other presenters have said, the first option is an open case where there's no plea. Second option is a diversion under diversion statute where it's a conditional plea, but if the period of supervision is successful, the charge is dismissed and expunged, so there's no record. The final option is a guilty plea and probation. So I believe all mental health courts try to act as diversion courts as much as possible because the goal of mental health courts is, quote, to decriminalize mental illness. So one way to help do that is obviously not to have people plead.
And I was just going to add that one of the reasons why having lawyers is so important is to avoid the problem that Mark described, where we're bringing people into the criminal justice system who really don't belong there. And one of the features, that we provide in our system, but I'm sure it's true across the board, is people don't go into these treatment courts if what they're saying is, hey, I wasn't the person who was involved in this. I'm completely innocent of these charges. I had nothing to do with it. They've got the wrong person. That's a reason that you don't go into a treatment court. Or if there is something about the evidence that the state is bringing forward that is just clearly inadequate in some way, those are not cases we want to see in these treatment courts. Treatment courts are for people who acknowledge that they have, been in trouble, that they've done something they shouldn't have done, but the key driver is these underlying sources that we think can be more effectively dealt with the treatment court intervention as opposed to a conventional, case processing.
I mean, there are hundreds of mental health courts across the country, and so I can't claim to know about all of them, but I have never heard of a mental health court in which defendants are asked to give up their right to counsel.
No, I don't think that happens. I can't believe it. And I've consulted with the other judges and helped set up other mental health courts, and that's never, ever been an issue that I've ever seen.
Gentlemen, let me pose another question to you regarding what happens when there's sanctions, when the person either fails a drug test or is not following other parts of the court-imposed treatment plan.
Well, as a judge, I can tell you there are sanctions that can be imposed. To be quite honest, I've been over backwards not to impose them if I could avoid it, because it defeats your purpose in many cases. But if you could, in certain instances, have, if they don't follow a guideline, you could have a probation violation petition filed and have a hearing on it. In certain instances, you could go a contempt route by not following a direct order and impose time. It always a quandary for a judge. I mean, you're placed in a difficult situation. You have public safety you have to deal with. You have all kinds of issues. But a treatment court is supposed to be a positive experience, and I tried to make it that way. And one way we did it, which is probably the most successful thing that I ever did, was I hooked up with a Subway corporation here in Nashville, the people that franchised them out here, and they were very interested in the court. So we gave away Subway cards. We gave $5 cards to everybody who was doing well. Every time they came to see me, if they had done well, they get a Subway card. And that was the most successful thing I ever did. And people would do anything to get a Subway card because they'd never been given anything in their lives, most of them, because they were impoverished. And so at the end, at the graduation, Subway would always be represented. They would come. We'd give them another gift from Subway. And in many cases, these folks would keep their cards that they had used and fan them out to show how many that they got and how proud they were of doing it. So I think it was Tom that mentioned the positive reinforcement. I think that's a huge part of any recovery court, is to recognize people's accomplishments and try to minimize the issues of having to punish somebody for a violation. But on occasion you have to violate the probation. If somebody gets arrested and charged with a serious crime, it is, and that happens. It's going to happen to everybody in this position, but it's a tough balancing act.
What I would say, two things about it. Graduated sanctions are what everyone wants to have. So when sanctions are necessary, in a normal criminal case, someone violates a pretrial order, don't have any positive urine tests, and you show up with a positive urine test. There certainly have been, in our history, judges who would say, well, okay, you were told not to use, drugs, and you have a positive UA, you're going to go into the jail until your case is resolved, and that's not graduated at all. It's an absolute, kind of punishment that gets imposed. Graduated sanctions are a big piece of how these things are resolved. But I think, and these rewards are really powerful. They're evidence-based, and they really make a big difference, and people will kill themselves to get these benefits, actually. It's really amazing. But the other thing I would say is that we see in the correct kinds of representation that individuals get from lawyers, that lawyers form a relationship with a person that's going through a treatment court, and they're paying attention to how the person's doing. And there have been many, many times where the person starts to falter, and sometimes the DA becomes aware of it, sometimes it comes to the defense attorney, but there is a professional way to start identifying that somebody's not doing well, and start to talk about what do we need to do to get this person back on the track. And a lot of the strength of these courts is that those conversations, which historically were very alien to legal culture, it was a very adversarial thing, we would never have a collaborative conversation. In these treatment court models, you get collaborative discussion, and you get people exploring, well, what can we do now so that this person does not end up having to have the program terminated for them. And it's exactly in that kind of collaborative work, I think, that some of the real success of these treatment courts can be found.
I couldn't agree more with that, and it seems to me one of the things that's part of a good mental health court culture is that the treatment providers and everyone else understands that if there is a quote-unquote failure, it might be that we failed to give you all of the necessary services you need, so that the change that needs to happen is that we may need to give you something more or offer you an alternative, or provide, or maybe we didn't offer the right amount or kind of services, and we will fix that before we just immediately assume that the failure is the defendant's fault.
Yeah, and that's a hugely important point about understanding these behaviors. These behaviors are, from a public health perspective, a warning, right? And people coming in who are not succeeding in the kind of community mental health services that they're getting, and they're getting arrested for disorderly conduct or assault and battery or something of this sort, that's a warning sign to us that there's something we're not doing correctly with our community mental health. It's at least as much that as it is this individual has a commitment to deeply antisocial thinking and is just acting out in an impulsive and dangerous way. I mean, it, of course, can be that, but it oftentimes is an indication that we need more medication, or the placement isn't the right placement, or there's something about the housing arrangements that are toxic for this person. And when you ask those broader questions, you get different answers and better interventions.
Thank you, gentlemen. I'm going to pose one more question to you because we're almost out of time. And it's a question about specific populations that may show up in your mental health courts. Questions around youth, young people and adolescents, veterans, and people who have suffered from traumatic brain injuries.
Well, what I saw was a shift, believe it or not, and began to see a lot more younger people toward the end of my 10-year tenure. Initially, we saw an older group of folks, and I don't know, I'm not sure why that happened. As far as veterans go, I started before all the veterans courts, actually, at the request of a VA worker in Nashville, started a separate veterans docket a number of years ago, wherein we had a separate caseworker from the VA that would come and work with the veterans. And it was very successful there, too, because you had the resources. The VA provided, although it took a lot of time to get in, it had more resources in many cases than I have in the other issues. Now veterans courts are as I would say, all the rage. There are numbers of them, and Davidson County has an actual separate veterans court that actually grew out of the docket I was running and is a whole separate docket. So we are seeing a lot of veterans.
Thank you, gentlemen. Our time is up, and I just would like to thank you all again for joining us today. And the Regional Policy Council would also like to thank our sponsors, Activists, Anonymous, Genentech, Janssen, Lilly, Otska, Synovian, and Takeda Lundbeck. The support of our sponsors made today's webinar possible, as well as all of the Regional Policy Council's activities in 2015. And we do, in fact, appreciate it. And again, for all of our listeners, we thank you for joining us. And I'll remind you that all the materials will be posted on the website, as well as the recording. We'll have the slides, and I'll ask our presenters for specific information that they've referenced. We'll put up information around the sequential intercept model and information about how determination of risk that Tom Reed mentioned, and we'll go through and we'll find any other information that was asked about specifically or anything else we think will be helpful to our audience. So again, gentlemen, thank you so much for joining us. We greatly appreciate your time, your expertise, and especially your deep understanding and compassion about mental health courts, and that they're not a one-size-fits-all. So again, thank you all so very much.